So, respected students, good afternoon. I told respected because you are really respected. Because on Friday, in this time, you are watching my lecture concerning bronchoobstructive syndrome. Okay, so bronchoobstructive syndrome or bronchial obstruction, it's a set of clinical manifestation resulting from generalized narrowing of the bronchi associated with airflow limitation on difference etiology. It's the definition of syndrome. It's a few signs occur together which different conditions. That's why syndrome of airflow limitation may be happening in different diseases, like bronchial asthma, chronic obstructive pulmonary disease, bronchiectasis, bronchiolitis, obstructive sleep apnea, gastroesophageal reflux, lung cancer, and eosinophilic granulomatosis with polyangiitis. It's the former name Church-Strauss syndrome, epiglottitis, subglottic stenosis, foreign body, and other. The main pathology mechanism which lead to airflow limitation, first, it's bronchospasm due to smooth muscles contraction. Second, it's hypersecretion dyskinesia, and also edema of the mucous membrane of the airways, and also compression of the bronchi, for example, due to emphysema, due to foreign body, and obstruction due to foreign body, and external compression, for example, due to other factor, including, for example, pulmonary edema. It's also lead to compression, not only alveoli, it's small size bronchi, also compression by excessive fluid in the lung. Complaints patient with obstructive lung disease, often chest tightness, inability to get a deep breath, whereas patients with congestive heart failure more commonly report a hunger or sense of suffocation. At temporal onset of duration of patient dyspnea, acute shortness of breath is usually associated with sudden physiological changes such as laryngeal edema, bronchospasm, myocardial infarction, pulmonary embolism, or pneumothorax. So it's patient with COPD experience a gradual progression of dyspnea on exertion, punctuated by acute exacerbation of shortness of breath. Most asthmatic have normal breathing the majority of the time, with recurrent episodes of dyspnea that are usually associated with specific triggers such as upper respiratory tract infection virus, for example, exposure to allergen and other. And the previous lecture we talked about cough can be divided in three categories. Acute cough, with cough duration less than 3 weeks. It's mostly accompanied by sinusitis, tracheitis, acute bronchitis, pneumonia, and for example, sometimes pulmonary embolism, also accompanied by acute bronchitis. Chronic cough, more commonly associated with obstructive lung disease, and other non-respiratory disease such as gastroesophageal reflux and postnasal drip. But now we discuss about very important and most often disease which accompanied by airflow limitation, bronchoobstructive syndrome. First place, it's asthma. We told that asthma is heterogeneous disease characterized by chronic airflow inflammation and more very important characteristic of asthma. All this process, chronic airflow limitation, lead to a variable expiratory airflow limitation. Variable. It's please note about it. Clinically, this variable airflow limitation have manifest like a wheezing, shortness of breath, chest tightness, and cough. And COPD, it's very interesting to change definition from the GOLD guidelines. For example, GOLD guidelines in 2015, COPD is common, preventable, and treatable disease characterized by persistent airflow limitation due to enhanced chronic inflammatory responses. But now, after 2017 and now, COPD is characterized by persistent respiratory symptoms due to anti-airflow limitation that due to airway and alveolar abnormalities, usually caused by significant exposure of noxious particles and gases. So it's very important because only information. We can't explain all causative factors which lead to airflow limitation. That's why more concrete, more correct, it's airway and alveolar abnormalities lead to persistent respiratory symptom and persistent airflow limitation. Please note that COPD characterized by persistent airflow limitation. Now, in the slide, you can see pathology changes in COPD and asthma. To the left side, it's asthma, right side, COPD. Information typically for both. In bronchial asthma and COPD, you can find the signs of inflammation. But information is crucial in case of asthma because it's affecting namely bronchus. In the COPD, not only bronchus, it's both problems in bronchus lead to airflow limitation, and in lung parenchyma it's due to emphysema, inflammation of emphysema. A variable airflow limitation in case of asthma can be explained by very significant smooth muscle hypertrophy. In the slide, you can see that 3+. Comparing with COPD, only 1+. It's not significant. But basal membrane also enlarged in patient with bronchial asthma and no changes in patient with COPD. Basal membrane of epithelial. But peribronchial fibrosis, it's most significant in patient with COPD. By the way, it's these changes lead to limitation of dilated bronchi under the influence of beta-2 agonist and anticholinergic drug. Bronchial fibrosis, like a ring throughout the bronchi. But also gap alveolar formation of emphysema. It's more typically for COPD. It's not accompanied by patient with bronchial asthma. And the difference, different trigger factor in case of asthma, mostly it's allergen, but it's not only. It's allergic mechanism. It may be not allergic. That's why definition of this asthma is allergic diseases was excluded from the definition. Cigarette smoking and pollutants for COPD. You told that bronchial asthma characterized by inflammation, and what type of cells play an active role in this inflammation? It's TH2, CD helper type 2. By the way, it's not only T helper. According to new data, also lymphoid cells type 2, dendritic cells type 2. That's why its information it's called T2. According to new guidelines, for example, in GINA guidelines, you can find this definition, T2 information. But comparing with bronchial asthma, in case of COPD, it's lymphocytes which infiltrate, play a role in inflammation. It's cytotoxic lymphocytes, CD8 lymphocytes, neutrophils. Due to neutrophils, this information, unfortunately, we have no ability to control this information because neutrophil not under the control of some more powerful pro-inflammatory factor like inhaled corticosteroids, and different cytokines in case of asthma, interleukins 4, 5, 13. In case of COPD, TNF alpha, interleukins 8, 1, beta, 6, and other. And this disease also can be differentiated and ruled out due to age of onset. Asthma onset mostly in childhood, but COPD diagnosis usually after 40 years. And symptoms in case of asthma due to its variable airflow limitation vary over time, day to day, in over a longer period, often limiting activity, often triggered by exercise, emotion, including dust, exposure of allergen can lead to exacerbate symptoms. Without bronchial asthma symptoms, patient may feel like a healthy person. But in case of COPD, it's chronic, usually continuous symptoms, typically. It's exacerbated during exercise, and patients sometimes stay about better and worse day, but all symptoms, including cough and dyspnea, present constantly. It's persistent symptoms. And lung function, but patients have variable airflow limitation, reversibility. It's not all cases. Bronchial delta reversibility have got patients with bronchial asthma. Sometimes, due to in case of severe inflammation, it's not good response to bronchodilators, short-acting beta agonists, for example. And in case of COPD, the main spirometry criteria is for all patients post-bronchodilators ratio between FEV1 and FVC. It's forced expiratory volume for 1 second and forced vital capacity less than 7. But please note about this criteria, the most criteria. Without this criteria, we can't make diagnosis COPD. But several times I ask patients at the practical classes, what the main criteria of COPD? Students say FEV1, it's moderate, severe. It's not true. Please note this criteria. Post-bronchodilators FEV1 ratio FEV1 to FEVC less than 0.7 on 70%. It's the main spirometry criteria of COPD. Lung function between symptoms, in case of asthma, it may be normal, but in COPD, persistent airflow limitations happen. In the case of history, past history, genetic predisposal more typically for asthma. It's family of asthmatic patient and other allergy condition. But in the case of COPD, maybe patient complains and information about chronic bronchitis or heavy exposure to risk factor, including tobacco smoke and biomass fuel. By the way, you should obviously to calculate the smoking history. For example, pack years. It's how many packs a patient smoking during 1 day, and you calculate for example, how many, and you ask patient about how many years patient are smoking. If, for example, 10 years for 1 cigarette, it means 10 pack years. Time course in case of asthma, it's no worsening symptoms over time. Symptoms vary either seasonally from year to year. May improve spontaneously or have immediate response to bronchodilators or inhaler corticosteroids over weeks. But due to COPD, due to its progressive, I told this one, symptoms slowly worsen over time, progressive course over year. Rapid-acting bronchodilators treatment provide only limited relief. X-ray, usually normal in case of asthma, and in case of severe hyperinflation of change of COPD. If patient have got, sometimes you can will meet with such situation. The patient has both symptoms, and asthma and COPD. Previously, it's called COPD, asthma, COPD overlap syndrome. Now it's combination asthma and COPD. It's a note about it, that one person have got 2 diseases, bronchial asthma and COPD. That's why you check and diagnose asthma, COPD overlap. And according to classification of asthma, also student miss the initial diagnosis and the diagnosis after start of control medication. It's divided asthma for intermittent and 3 types of persistent. It's due to its initial diagnosis. It's diagnosis of first contact with patient. Patient a naive for control medication. No, you will not don't use previously any medication except, for example, short-acting beta agonist. But its classification severity, it's from 202. But now step 1 in the intermittent asthma significantly slightly changed. For example, it's characterized by symptoms 2 times a week, 2 times a month. It's night awakeness and also normal spirometry data. And but step 2 symptoms more than 2 times a week, but less than daily. And step 3 very easy, moderate persistent asthma. It's daily symptoms and practically continuous symptoms in severe persistent bronchial asthma. And please, it's first step. GINA 2019 have got a fundamental change in asthma management. First of all, now it's not longer recommended treating adults and adolescents with asthma with short-acting bronchodilators alone. Other way, it's monotherapy of SABA, short-acting beta agonist, is now prohibited, monotherapy. But why? Because a lot of patients with so-called mild asthma use only SABA, only reliever medication. Because asthma is not bothering this patient significantly. And now such results that patients with mild asthma have got a risk of serious adverse events like 30% and more acute asthma, fatal, approximately 20% of fatal asthma, and died to the asthma. That's why bronchial asthma, mild bronchial asthma, is not good asthma. It under the influence of trigger, for example, allergen, pollutants, virus infection. Mild asthma may be transferred to fatal asthma. That's why, because it's chronic inflammation, typically for all group patients with bronchial asthma. By the way, regular and frequent use of SABA is associated with adverse effects like beta receptor downregulation, increased allergic response, increases eosinophilic flow inflammation, and also if patient dispensing over 3 canisters per year is associated with higher risk of emergency department if more than 20 canisters per year of SABA is associated with high risk of death. That's why if you ask patient how many salbutamol you often consumption monthly, if patient say 1 canister, it's high risk of death, by the way. So for safety, GINA no longer recommended SABA only treatment for step 1. GINA now recommended that all adults and adolescents with asthma should receive inhaled corticosteroids containing controlled treatment to reduce the risk of serious exacerbation. So in this slide you can see, for example, if patients have symptoms twice a month and more, if less than twice a month and more, patient recommended first step. It's so-called intermittent bronchial asthma step 1 now, concerning new GINA 2020 recommendation. As needed low doses inhaled corticosteroids plus formoterol. Formoterol, it's LABA. It's a long-acting beta agonist. But formoterol have comparing with other LABA medication have got a very rapid onset of the start of the bronchodilation in 5 minutes. That's why it's this, namely formoterol, can recommend it for treatment, but it should be a combination with inhaled corticosteroid, because symptoms of asthma, it means uncontrolled inflammation. That's why patients should obtain new dosage inhaled corticosteroids, because our main goal that inflammation should be under our control. Symptoms twice a month, daily dosage of inhaled corticosteroids, or as needed low dosage inhaled corticosteroids, formoterol. And symptoms most day, but patients such recommended step 3, low dosage inhaled corticosteroids plus LABA. Maybe so-called MARC therapy, when one devices we can use for maintenance of control and for relief medication. For example, inhaled corticosteroids plus formoterol, like budesonide. SMART therapy, it means Symbicort, which for two purposes. At night, at morning, patient use for control medication, and other inhalation of this Symbicort, maybe for as a relief medication is needed. And if patient symptom most days, it's reduce lung function. Recommended medium dosage inhaled corticosteroids plus long-acting beta agonist, medium dosage. Because previously it was recommended high dosage of inhaled corticosteroids, but now it changes it more gently to relation to high dosage because serious effect, including systemic circulation, including increased risk of pneumonia, for example. That's why we try to avoid and start with medium dosage inhaled corticosteroids in step 4. That's why it's initial control. I told initial control, initial medication. Now it's you can see what changes in GINA guidelines. You can see step 1, preferable control medication is needed low dosage inhaled corticosteroids plus formoterol. And for reliever medication, you can see as needed low dosage inhaled corticosteroids plus formoterol. But by the way, more evidence we have for budesonide plus formoterol. It's, for example, Symbicort, trade name. It's step 2. It's not changes low dosage inhaled corticosteroids, but daily low dosage inhaled corticosteroids or as needed low dosage inhaled corticosteroids plus formoterol as a control medication. But step 3, low dosage inhaled corticosteroids plus LABA, it's first choice. If step 2 it's low dosage corticosteroids, but in step 3 obviously combination inhaled corticosteroids plus LABA. Step 4, medium dosage inhaled corticosteroids plus LABA. In this step we can add to medium dosage inhaled corticosteroids plus LABA if we didn't reach to control. We can add triple therapy, it's tiotropium bromide. But high dosage, previously in previous edition, for example 2090, it's high dosage inhaled corticosteroids will be at the step 4, but now it's transferred to the step 5. High dosage inhaled corticosteroids plus LABA plus phenotypic assessment and recommended biological therapy like monoclonal antibody against IgE, against receptor interleukin 5 and against interleukin 5 and receptor interleukin 4. We will say about it later. But more preferable reliever medication for all group, it's inhaled corticosteroids plus formoterol. But if patient use corticosteroids as a control medication, patient can use only salbutamol, but it's under the ground of systemic inhaled corticosteroids. It's very important. So it's how can we monitor a patient with bronchial asthma? And for example, our prescription of medication, it's only initial step, but we should monitor a patient constantly, patient with bronchial asthma, and patient after first visit, we should assess the control. And I asked several times, what does it mean? Control asthma, not control asthma. Students don't know about it, but please check yourself. At the next visit, for example, at least in 1 month and more, it's because we can make evaluation of the level of control in past 3 weeks. That's why patient should go after 4 weeks. If patient don't have any exacerbation or condition seriously worsening. And you ask only 4 questions. Please know this question. Daytime asthma symptoms more than twice a week? If no, it's 0. If yes, it's 1 point. Any night awakenings due to asthma? If patients say no, it's 0 point, yes, 1 point. Relief medication needed for symptoms more than twice a week, but now it's, by the way, recommended not reliever, because reliever it may be combination inhaled corticosteroid plus SABA, but now recommended only SABA, ask SABA. More than twice a week, if patient yes, 1 point, no, 0. Any activity limitation due to asthma, yes, 1 point, no, 0 point. And what does it mean? Well-controlled asthma, it's asthma 0, it's none of these symptoms, it's 0. From 1 to 2 point, it means partial control of asthma. And 3 and 4, it's uncontrolled asthma. That's why next visit we come back to, we firstly should assess severity of bronchial asthma. How can we assess? We should know, you should ask about using control medication. If patient have got, for example, step 2, it's mild asthma, low dosage corticosteroids. That's why we indicate mild bronchial asthma. But if patient nevertheless have got all these symptoms, we should indicate mild bronchial asthma uncontrolled. If patient have got medication according step 3, it means moderate bronchial asthma. And also you should assessment control according to this question, 4 question. Patient who have patient with bronchial asthma who obtain the therapy according to step 4 and step 5 has severe bronchial asthma. But patient, for example, obtained medium dosage corticosteroid plus LABA plus tiotropium may be reached to control and no symptoms. That's why it's you indicate patient have got bronchial asthma, severe course, controller. What should we do if we reach to control? This control should be continued during 3 months. After 3 months, we can make a conclusion about go step down. For example, if patient obtained medium dosage inhaled corticosteroids plus LABA, we can go to the step 3, low dosage inhaled corticosteroids. And opposite, if we patient have worsening situation, for example, no reach control to step 4, we go to step up for step 5. High dosage inhaled corticosteroid plus LABA. That's why it's this scales approach help you to reach control. The main goal of the treatment of bronchial asthma is reach control. But now it's a general recommended reliever medication. It's short-acting beta agonism. And in this slide, you can see the dosage of corticosteroids. For example, if patient use beclomethasone, it's low dosage 250 microgram daily. If medium 500, 1000, and more than 1000 higher doses. That's why it's dependent from by the way, response for inhaled corticosteroids is for patients with bronchial asthma is dose dependent. That's why if you don't reach control for lower dosage corticosteroids, you can reach control to medium dosage inhaled corticosteroids. By the way, the second goal for treatment of bronchial asthma is diminish of risk of exacerbation, especially life-threatening exacerbation. How? Firstly, it's the risk factor can be divided for modified risk factor and not modified. Now, for example, if patient was intubated for asthma and in intensive QA units, patient have got such exacerbation which need to hospitalization in ICQ, it means not modified risk factor. But patient, for example, smoking, obesity, blood eosinophilia, allergy reaction, and other uncontrolled asthma symptoms, it's modified risk factor. But we should fight against modified risk factor. It's very important to diminish risk factor for severe exacerbation and for severe exacerbation. In this slide, it's a new approach to assessment of phenotype of bronchial asthma. But now all asthma can be divided in main two endotype, T1 or not T1. T1 higher, which typically for patients with atopy, and when IG have got a great role, and T2 lower. It's patient mostly in case of allergic inflammation, but more typically eosinophilic inflammation. For example, patient who have got a sensitization on skin prick testing or have got a high level of specific IgA, and patients have got exacerbation in the last year and non-reach control if patient use, for example, triple therapy, including high dosage in high corticosteroids. We should think about the prescription of monoclonal antibody against IgE. But for indication, it's blood eosinophils more than anticorals 260 per microliter. Escalation NO, it's more than 20. Allergen-driven symptoms and childhood onset of asthma. It's but for patients who have a higher blood eosinophils in the sputum, more exacerbation of previous year, adult onset of asthma, nasal polyps, it's more preferable to prescribe anti-interleukin 5 or anti-interleukin 5 receptor blocking monoclonal antibody, including restylizumab and mepolizumab. And if patient have got higher blood eosinophils, have escalation NO, and moderate severe atopic dermatitis, nasal polyps, patient can be recommended treatment with using anti-interleukins 4 receptor and monoclonal antibody. It's called dupilumab. It's new guidelines. If you met with situation you can differentiate asthma from COPD. For example, if you show that it's high likely to be asthma, you should treat as asthma and do not give long-acting beta agonism and long-acting cholinergic drug without inhaled corticosteroids, obviously. You should try to avoid prescription oral corticosteroids. And if all symptoms confirming about more probable, maybe both asthma and COPD, you should treat as asthma. Also, it's same recommendation, but you may be combined, add to asthma treatment recommendation concerning, for example, COPD. For example, triple therapy plus roflumilast you can prescribe. If you like to be COPD, you should treat as a CB according to GOLD guidelines. And but what about leukotriene's receptor antagonist? It's, for example, montelukast singular. FDA now have got a report coding side effect. These drugs, including suicidality in adults and adolescents, and change of behavioral problems in children. That's why be careful if you prescribe montelukast with this patient. Few words about COPD. You can see it's in GOLD, a global strategy for diagnosis and management and prevention of chronic obstructive pulmonary disease. And if a patient have such symptoms like shortness of breath, chronic cough, and sputum, and risk factor, for example, tobacco smoking, host factor, occupational factor which influence to respiratory tract, indoor, outdoor pollution, you should send patient for spirometry investigation for establishing, it's necessary for establishing diagnosis of COPD. But dyspnea for COPD, it's progressive over time. Characteristic was with the exercise and persistent. Chronic cough may be intermittent and may be unproductive. Chronic sputum production, any pattern of chronic sputum production may indicate COPD. And history of risk factor, including host factor, tobacco smoking, occupational, I talked about it. And as a case of chronic cough, by the way, it's asthma, lung cancer, we should exclude tuberculosis, bronchiectasis, heart failure, interstitial lung disease, cystic fibrosis, idiopathic cough. And extrathoracic, including chronic allergy, rhinitis, postnasal drip syndrome, upper airways cough syndrome, gastroesophageal reflux, and medication. For example, patient may be use ACE inhibitor and lead to chronic cough. And the main spirometry criteria for COPD, it's a ratio between FEV1 and FEVC. It should be less than 0.7. To the right part of this spirography investigation, you can see FEV1 0.56. It means it's typically for asthma. But severity of airflow limitation can be assessment by using of FEV1 only. But it's mandatory, obligatory requirements for this situation. This patient should have got main spirographic criteria post FEV1 or FEVC less than 0.70. But according to GOLD, it can be divided into the fourth category: mild, moderate, severe, and very severe. And for example, patient who have got a spirography criteria of COPD, but FEV1 more equal 80% from predictable level, it's mild severity of airflow limitation. Moderate, it means from 50 to 80% from predictable level. Severe, from 30 to 50, and very severe, less than 30% from the predictable level. And also in patients with COPD, patients should fill in 2 questionnaires. It's first, it's modified MRC dyspnea scale, and for example, it's different grade of dyspnea. For example, 0.1, I only get breathlessness with serious exercise, and a patient with grade 4, I am too breathless to live at home. I am breathless when dressing or undressing. That's why if patient check, for example, 2, you in case of history, you can indicate patient suffering from dyspnea in breaks, MMRC grade 2. Also, you can use COPD assessment test. Patient also fill in this form. For example, it's a different question. For example, I never cough, it's 0 point. I cough all the time, it's 5 point. And patient who have more than 10 summarize point for this question, it means high symptoms, high influence. That's why also as the patient have more than 2 grade or equal to grade of MMRC. That's why in this classification, according to last classification 2020 due to GOLD, and first step, you should patient should meet this criteria of spirography criteria. After firstly is clinically breathlessness, dyspnea and cough, tobacco smoking, and all signs due to physical examination, other. And you should, but obviously, next step after spirometry investigation, presence of this criteria: post bronchial dilatus ratio, FEV1, FEVC less than 7. Please note about it. Then we assessment of airflow limitation due to GOLD 1, 2, 3, 4. And then we ask patient about the history of exacerbation. Patient due to history exacerbation can be divided in 2 categories, with low exacerbation and high. If patient have a 0.1 exacerbation not leading to hospital admission, it means group A and group B. And patient have got more than 2 exacerbation during last year not leading to hospital admission, or 1 or more leading to hospital admission, it's belong to group C and D. But differentiation between this group, it may be group A and C have MMRC 0.1, cut less than 10. It means no more symptoms. Patient group B and D have get more symptoms, more influence for the health. So role of spirometry, it's assessment. It's very important criteria for diagnosis, severity of flow limitation, and also it's needed for follow-up assessment patient with COPD. And differential diagnosis of COPD, firstly it's asthma, congestive heart failure, because also patient with congestive heart failure can suffer from cough and dyspnea, bronchiectasis, tuberculosis, and other, including, by the way, lung cancer. But for goal for treatment, it's reduce symptoms and reduce risk, prevent disease progression, prevent and treat exacerbation, and reduce mortality. Reduce risk means reduce mortality. No, reduce symptoms, you understand what does it mean? And when we make diagnosis for COPD, and after investigation, complete clinical, maybe in primary care investigation, if patients with stable COPD, you should recommend it first. It's smoking cessation, vaccination, firstly anti-flu, anti-pneumococcal vaccination, and change in lifestyle, and initial pharmacotherapy and self-management education to risk factor management, inhaler technique, and treat comorbidities, and also patient should obtain written action plan. And after next visit, you should analyze symptoms using ONCAT or MMRC. You should know about history of exacerbation, smoking status, and you obviously should, the smoking status and smoking should be your control and attention. Ask, and patient should stop smoking, because this high level of evidence benefit of this stop smoking. Physical activity and exercise, inhaler technique, because sometimes patient, due to patient with COPD especially, have got a very bad inhaler technique, so these drugs pass into the gastrointestinal tract, not in the respiratory tract, due to incorrect inhaler technique. And you should treat learn patient about self-management skills, and patients should have written action plan, and adjust pharmacotherapy and not pharmacotherapy. So initial pharmacological treatment for group 1 including bronchodilators. For group B, it's long-acting bronchodilators. For group C, also it's maybe this last LAMA, but because patients have got a higher level of exacerbation, firstly you should fighting against this risk factor of exacerbation, including tobacco smoking. It's necessary vaccination, lifestyle modification. And group D, it's maybe start with LAMA, then edit LABA. In some cases, I will say about it later. It's triple therapy, LAMA, LABA plus inhaler corticosteroids, and other treatment. But in this slide you can see, and you can find this commonly used medication for COPD in GOLD guidelines. And what about inhaler corticosteroids? And it's dependent from some kinds of factor which inform you that corticosteroids will be the prescription corticosteroids will be benefit for patient of COPD. Firstly, it's strong support in inhaler corticosteroids. It's patients have got more to moderate exacerbation of COPD per year. And very important thing is blood eosinophilia, more than 30 cells per microliter. And also, if patients have overlap syndrome, concomitant asthma, it's obviously strong support. Consider use if one moderate exacerbation of COPD per year and blood eosinophils from 100 to 300 cells in 1 microliter. And gauge use at repeated pneumonia events, blood eosinophils in less than 100 cells, and history of mycobacterial infection. That's why you should know it's, by the way, monotherapy of inhaled corticosteroids for patients of COPD is prohibited. It's obviously you should start with bronchodilators. Pulmonary rehabilitation is very important. That you can see it's evidence A, highest level. Educational self-management, integrated care program. Sometimes patients which have got a progressive dyspnea, it's desaturation, need to oxygen therapy, sometimes on non-invasive ventilatory support. And management cycle including assess inhaled techniques, not pharmacological approach, adjust, escalate treatment, switch inhaled device or molecules, or de-escalate. For example, if D group patient monitoring during 1 year and no exacerbation and only one exacerbation not require hospitalization, patient can transfer to the C group, to the B group. That's why I review symptoms and dyspnea exacerbation. It's obviously for all visit from first visit to other visit of patient, and follow up pharmacological treatment if, for example, dyspnea exacerbation including, for example, escalation and de-escalation. For example, you can start with monotherapy LABA or LAMA and add dual LABA plus LAMA, and add, for example, inhaled corticosteroids if we have indication, for example, eosinophils more than 300 in microliter. In case of exacerbation, also we can escalate therapy, for example. But if a patient have obtained dual bronchodilators LABA plus LAMA, we can recommend, if patient have more eosinophils more than 100 plus inhaled corticosteroids, if less than 100 at roflumilast, or in case of infective exacerbation, especially in former smoker, plus azithromycin macrolide. And not for pharmacological management of COPD, including smoking cessation, including physical rehabilitation, physical activity, flu pneumococcal vaccination for all group practically. And patients who have got a drop of saturation less than 88 should use, for example, concentrator of oxygen and long-term oxygen therapy for keeps saturation more than 90%. And in 60 or 90 days, you should assess if supplemental oxygen is still indicated, if prescribed supplemental oxygen is effective or not effective. And differential diagnosis of COPD exacerbation, firstly, it's pneumonia. It's for this case, you should make chest radiography of assessment of C-reactive protein or procalcitonin. Also, for example, pneumothorax may be because formation of bulls due to bullous emphysema. It's lead to sometimes destroy bulls and chest and lead to pneumothorax. This chest radiography of sometimes ultrasound help you to make this diagnosis. Pleural infusion, the same investigation, chest radiography and ultrasound investigation. Pulmonary embolism, it's chest computer tomography, pulmonary angiography, and D-dimer in case of hemodynamic stability. And for example, pulmonary edema due to cardiac relative condition, firstly it's ECG, cardiac ultrasound, and cardiac enzymes is 2. And cardiac arrhythmia, atrial fibrillation, electrocardiogram, maybe Holter monitoring. Potential indication for hospitalization, assessment, severe symptoms such as sudden withering results in dyspnea, high respiratory rate, decreased oxygen saturation, confusion, drowsiness, acute respiratory failure. It means acute on chronic, because patients sometimes have got a chronic respiratory failure, but it's so phenomenon, acute on chronic. Onset of new physical signs, cyanosis, peripheral edema, failure of exacerbation to response to initial medication management, and presence of serious comorbidities, insufficient of home support, and local resources need to be considered. And management of severe but not life-threatening exacerbation, including assessment severity of symptoms, blood gases, pulse oximetry, chest radiography, administers supplemental oxygen therapy, bronchodilators, increased dosage combination, for example, short-acting beta agonism and anticholinergic drugs. Consider use of long-acting bronchodilators when patient becomes stable. Use special air-driven nebulizer. You should consider about prescription of patient oral corticosteroids. Consider antibiotics when bacterial infection are present. Consider non-invasive mechanical ventilation at all time, monitoring fluid balance. Consider subcutaneous heparin or low molecular weight heparin for prophylaxis thromboembolism complication, and improving, by the way, circulation in the blood and the capillary bed, and identified treat associated conditions like heart failure, arrhythmias, pulmonary embolism, and other. Key point for the management of exacerbation, short-acting inhalated beta agonism, evidence systemic corticosteroids, antibiotic, methylxanthines are not recommended, by the way, due to increased side effect profiles because it's very closely therapeutic and toxic concentration. So the next clinical sites which lead to airflow limitation and bronchiolitis is a general terms used to describe a non-specific inflammatory injury that primarily affect the small airways, less than 2 millimeter in diameter. And classification of bronchial disorders: acute bronchiolitis, constrictive bronchiolitis, respiratory bronchiolitis, diffuse punctal bronchiolitis, follicular bronchiolitis, and mineral dust airway disease. But sometimes bronchiolitis may be accompanied by interstitial lung disorders, respiratory bronchiolitis associated with interstitial lung disease, with discriminative interstitial pneumonia, cryptogenous organizing pneumonia, pulmonary lung organ cells histocytosis, sarcoidosis, and other. Large airway disease, which bronchial involvement, other bronchial disorders, including diffuse aspiration, bronchiolitis, lymphocytic bronchiolitis, and other. Etiology: infection. Firstly, it's viruses, different adenovirus, rhinovirus, enterovirus, human metapneumovirus, mycoplasma pneumonia, inhalation injury, nitrogen oxide, ammonia, welding fumes, and drug-induced process, gold penicillamine. Other potential causes: aspiration, lung and bone marrow transplantation, connective tissue disease, Stevens-Johnson syndrome, for example. Pathological change of airways, typically for bronchiolitis. In the lower airways, subsequent bronchial inflammation and invasion of white blood cells, mostly mononuclear cells, edema on the submucosa and adventitia. Airways can be partially or totally obstructed by plaques or necrotic epithelium and fibrin, sometimes with a valvular mechanism resulting in trapping of air. Distal to obstructive areas, atelectasis is mismatch of pulmonary ventilation and perfusion. The cytokines can recruit and activate neutrophils, lymphocytes, macrophages, eosinophils, and natural killer cells. Can also increase mucus production and airway hyperactivity. Clinical picture: tachypnea, tachycardia, and prolonged aspiration. On physical examination reveals tachypnea and biparallel ends in inspiratory dry crackles. Crackles may be present in absence of radiographic abnormalities. On the chest radiography, scattered late inspiratory high-picted rhonchi, so-called inspiratory squeaks. The cardiac examination is usually normal except in the middle or late stage of the disease when findings of pulmonary hypertension and choropulmonale may become evident. Cyanosis and clubbing of the digits occur in some patients with advanced disease. And higher resolution computer tomography, it's ground glass opacity, air trapping, especially due to exhalation, during exhalation, bronchial wall thickening, and central lobular nodules like a V and Y-shaped branching linear opacity, subpleural distribution, patchy consolidation of ground glass opacity is a characteristic finding of proliferative bronchiolitis. That's why it's very important for diagnosis. Treatment: administration of oxygen, adequate hydration, at least 70–80% of usual daily requirement, but should not exceed 100%. Hypertonic saline inhalation plus bronchodilators. Continual positive airway pressure, CPAP, may improve respiratory failure and help avoid intubation of patients with intensive care unit. In bronchiolitis due to toxic inhalation injury, glucocorticoids are occasionally effective in the management of both the acute phase illness, pulmonary edema, and the late phase illness, bronchiolitis obliterans. Macrolide antibiotics have been increasingly used in the management of bronchiolitis because of their success in improving symptoms, lung function, and mortality, mostly in bronchiolitis associated with mycoplasma infection. So, for differential diagnosis, I told the start of my lecture about eosinophilic granulomatosis polyangiitis, Charles-Stross syndrome. This complex syndrome is characterized by eosinophilic vasculitis that may involve multiple organ systems, including the lungs, heart, skin, gastrointestinal tracts, and nervous system. And primary features of this syndrome, it's signs of asthma, peripheral eosinophilia, neuropathy, pulmonary infiltrates, paranasal sinus abnormality, and eosinophilic vasculitis. The prodromal phase, this syndrome is characterized by asthma and allergic rhinitis, and usually begins when the individual is in his and her 20s or 30s, typically persistent for many years. It's characterized by peripheral eosinophilia, mostly in hypereosinophilia, and eosinophilic tissue infiltration of various organs, including the lungs and GAT. The third phase in the vasculitis included weight loss, fever, diffuse myalgias, and migratory polyarthritis. Myositis may be present with evidence of vasculitis of multiple biopsies. Respiratory symptoms, including asthma, can often be severe, and oral corticosteroids are often required to control symptoms. Cough, dyspnea, sinusitis, and allergic rhinitis, alveolar hemorrhage, and hemoptysis may also occur. Neurological symptoms, including mononeuritis, multiple, most commonly involved in perineural nerves, but also involve the ulnar, radial, internal, and other cranial nerves. Cerebral hemorrhage and infarction may also occur, important causes of death. Despite treatment, neurological sequelae often do not completely resolve. Dermatological palpable purpura, skin nodules, urticarial rash, livido. Cardiovascular, acute pericarditis, constrictive pericarditis, myocardial infarction, and other ECG changes may occur. GI symptoms, abdominal pain, diarrhea, bleeding, and colitis, ischemic bowel, pancreatitis, and cholecystitis. Renal proteinuria, glomerulonephritis, renal insufficiency, and rare renal infarct. Lab abnormality, including increased level of eosinophilia greater than 10%, is one of the defining features of this illness, and may be higher at 75% of peripheral white blood cells count. Antinuclear cytoplasmic antibody are present. Its answer: antibody are present up in 2/3 of patients. Significant elevation erythrocyte sedimentation rate, normochromic normocystic anemia, and elevated IgE, hyperhemoglobinuria, and positive rheumatoid factor or antinuclear antibody may be detected too. Pavlov revealed significant eosinophilia. But spirography and other tests revealed obstructive defects similar to bronchial asthma. Computer tomography findings include bilateral ground glass opacity and space consolidation that is predominantly subpleural, include bronchial wall thickening, hyperinflation, intralobular septal thickening, lymph nodes enlargement, and pericardial pleural effusion. Treatment, it's inhaled corticosteroids, cyclophosphamide, azathioprine, methotrexate, intravenous gamma globulin, interferon alpha, anti-IgL antibodies. Hypereosinophilic syndrome constitutes a heterogeneous group of disease. Entitis manifests by persistent eosinophilia, more than 1,000 eosinophils in milliliter, associated with end organ damage or dysfunction, and this secondary cause of eosinophilia. And last part of my lecture concerning respiratory failure and results from disturbance of gas exchange due to impairment in either oxygenation or elimination of carbon dioxide on both. For clinical routine purposes, respiratory failure is usually defined by arterial oxygen tension less than 60 mm mercury and arterial carbon dioxide tension greater than 45 mm mercury. Therefore, the diagnosis of respiratory failure is a laboratory one, but the important point to emphasize is that these cutoff values are not rigid. They simply serve as a general guide in combination with history and clinical assessment of the patient. Type 1 respiratory failure is functional failure of the lung itself primary, results in arterial hypoxemia associated with normal or even reduced level of carbon dioxide, pressure of carbon dioxide, as a consequence of compensatory augmented ventilation. Type 2 is hypercapnic respiratory failure. It's caused by mechanical disadvantage such as lung hyperinflation in COPD, central nervous system abnormalities of respiratory muscle dysfunction, and lead to elevating pressure of carbon dioxide level, often in company with hypoxemia due to alveolar hypoventilation. And so, respiratory failure can divide in lung failure, gas exchange failure manifested by hypoxemia, and pump failure, ventilatory failure manifested by hypercapnia. And respiratory failure can be divided into two categories: acute, for example, and chronic. Example, acute respiratory failure, it's, for example, acute respiratory failure accompanied by pneumonia. Chronic respiratory failure, it's, for example, typically for patients with COPD, bronchiectasis, or interstitial lung disease like pulmonary fibrosis. Sometimes chronic respiratory failure can be exacerbated due to exacerbation of main disease. For example, patient, it's a so-called phenomenon, I talked about it, acute on chronic. By the way, previously, it was classification according the grade of dyspnea. Now it's not true. Only lab monitoring can and instrumental monitoring, but detection partial oxygen pressure in the arterial blood or oxygen saturation may help you to detect the respiratory failure severity. For example, normal range for oxygen in the peripheral blood, in peripheral artery blood, more or equal 80 mm hydrogen mercury. For saturation, more or equal 95. Respiratory failure grade 1, it's correspondingly 79 to 60 milliliter mercury pressure of oxygen in artery blood, and saturation from 94 to 90% using pulse oximetry technique. And grade 2 pressure of oxygen in arterial blood from 59 to 40, and saturation of oxygen from 89 to 75. and drop of oxygen pressure in arterial blood less than 40, and saturation of oxygen less than 75, it means respiratory failure grade 3. But now it's all material that I would like to give you. It's new material. This material based of the latest guidelines of GINA, COPD, and other new data concerning differential diagnosis of bronchoobstructive syndrome. But in this lecture, I can't to give you all information, but you should know. But sometimes it's not only respiratory disease can lead to bronchoobstruction. For example, you should ask question about symptom of gastroesophageal reflex disease and other, and but for main cases, differential diagnosis of bronchoobstructive syndrome should be meet with bronchial asthma, COPD, and other disease. It's more rare. By the way, acute bronchitis also can be associated with airflow limitation, but chronic bronchitis also due to exacerbation may lead to airflow limitation. But in case of chronic bronchitis and acute bronchitis, this disappear of exacerbation of chronic bronchitis and recovering from acute bronchitis in all cases should be lead to disappear the symptoms of bronchial obstruction. But we can use as a symptomatics bronchodilators like short-acting beta agonism, short-acting anticholinergic drugs in combination with therapy of this disorder. That's why, but it's a problem for differentiation of disease is very important. Sometimes it's very difficult. And for example, if you make diagnosis of chronic obstructive pulmonary disease and you start treating with bronchodilators, and suddenly maybe significantly improving condition and normalize, for example, normalize results of spirometry. That's why you should change diagnosis, and you should stop diagnosis for COPD and change for diagnosis bronchial asthma, because it's COPD, I would like to repeat once more, it's persistent airflow limitation. Bronchial asthma is variable. That's why we only constants that, for example, COPD patients have got a GOLD 1, GOLD 2, GOLD 3, but we should not wait that under the influence of our treatment, this airflow limitation in case of COPD significantly improved because it's persistent. And morphological changes in bronchi and lung support this persistent airflow limitation, including, first of all, it's peribronchial fibrosis and emphysema, which compress bronchi, and it's not it's very significant limitation for enlarged size of bronchi. Nevertheless, the treatment of bronchodilators. That's why this final that I would like to say. If you have any question for me, I try to answer and explain. But it's strange for me. You have got a lecture in COPD bronchial asthma, but when I repeat a question during practical classes, it's very simple question. Often you have incorrect answer. So, for example, what type of airflow limitation in case of patient of bronchoasthma or COPD? What main spirography criteria of COPD? We repeat once more. It's post-bronchial dilators ratio FEV1 FEVC. I bet such a question you will meet in your exams and your fatherland. It's we met with such question due to our license exams when we confirm our category. That's why it's a very important thing, and please ask me about this lecture. I am waiting 5 minutes question. There are no questions. I would like to say you goodbye. Be care. All the best.